Kubian, and I'm a certified patient navigator at the Breast Cancer Resource Center in Austin, Texas. The medical community has been working hard to ensure the safety of patients and staff while preparing for the expected increase of critical care needs for those with COVID-19. Because of this, there have been some significant changes in treatment and surgical plans for those diagnosed with cancer. To help those with breast cancer in our community, the Breast Cancer Resource Center has asked a few of our medical professional partners to shed some light on cancer care decision-making due to COVID-19. Today, I'm grateful to have medical oncologist Dr. Beth Hellerstedt with Texas Oncology. Dr. Hellerstedt has a fellowship in hematology and oncology from the University of Michigan, Ann Arbor, where she also did her internship. She received her medical degree with highest honors from the University of Pittsburgh and was awarded the GlaxoSmithKline Research Fellow at the University of Michigan Medical Center in 2001-2002, the National Service Research Award from the National Institutes of Health in 2001-2002, the Bronze Beeper Award, Excellence in Residence Training in 1999, an elected member of the Alpha Omega Alpha Medical Honor Society from the University of Pittsburgh School of Medicine in 1997. Dr. Hellerstedt, thank you so much for joining me today.
Thank you. It makes me realize how long I have been here and how old I currently am.
So let's get to some questions about the current situation that everyone's facing. So for breast cancer patients that are currently undergoing chemotherapy or maybe just recently completed chemotherapy, are they at higher risk for contracting or having adverse effects from COVID-19?
Well, I think we are always worried about our patients as they're going through chemotherapy because of their potential increased susceptibility to infections of all kinds, and certainly COVID is no exception. COVID seems to be, in some respects, an exception almost the other way around. Obviously, completely immunocompetent people have seemingly equal risk of developing the infection. It's also a situation where our patients are hopefully having very short periods of time when their blood counts are low. So trying to get them through each cycle and evaluating, from time to time is something that we're planning, and it's something that we prepare for every patient, even in times of non-COVID situations. So I think that from the standpoint of how we approach patients, we certainly approach patients with the eye toward COVID, but if we think about how we actually approach patients even outside of those realms, it's a very similar idea. It's an idea of understanding when that risk is going to occur, understanding the depth and length of that risk, and trying to manage that risk while still allowing them to receive the full benefit of the treatment that really needs to happen for them in the long term.
Great. And how long would someone after completing chemotherapy or being completed with active treatment still be considered immunocompromised?
Well, from the strict definition of immunocompromised is really when the white blood cell count gets back up into the normal range, when the neutrophil count is greater than 1 is sort of our strict definition. But I think part of that definition also includes the idea of a maintenance of normal health, if you will. And sometimes that maintenance will take a bit longer than simply the recovery of the white blood cell count. So for some patients, depending on their chemotherapy, the type of chemotherapy, they may come to the end of their treatment with an intact white blood cell count and otherwise excellent performance status, and they're probably not at any particularly increased risk over baseline. Whereas other patients, even when their white blood cell count recovers, if they're still recovering from a nutritional standpoint, from an activity standpoint, from a sort of quality of life standpoint, we may have to pay them additional attention and care for several more weeks until they can achieve those non-numeric goals.
Gotcha. Okay. And if you're still having chemotherapy, is it safe to go to the infusion clinic right now to get those chemotherapy treatments?
Well, I think we're all working as absolutely hard as we can to ensure that patient safety is first and foremost. We've started policies of testing every patient as they come in for temperature and any symptoms. We test the employees twice a day and keep a fever log. We keep a symptom log for the employees. We employ masking as per the CDC guidelines. Those guidelines are constantly changing, so we're constantly evolving to keep up with them. We're also doing a number of such a high volume of phone triage so that patients are very aware of this risk. And if they are having symptoms, they don't want to bring it, to the clinic. So our nurses are doing quite a number of phone triage and connecting them with resources to either be tested for COVID if it's appropriate, but also to remember that our patients do, and every patient does, still have risks of other things. So we can't be so focused on COVID that we forget about, all of the other things that we need to consider in a patient's, treatment and in that triage. So we're trying to ensure that patients have that access to COVID testing and are able to do so safely and outside of the clinic. But we also never lose touch with the patient as far as what other things that we need to consider. So some patients may also be referred for COVID testing, but get an antibiotic, or get referred for COVID testing, but also let's get a flu swab and think about Tamiflu, so that we make sure that we cover all of our bases. We can't be so COVID focused to the exclusion of everything else.
Right. We can't forget there are other things out there that were Correct. Things we had to think about before COVID. Right. Exactly. Okay. Makes sense. We've been hearing that some oncologists are looking at reducing the length of chemotherapy for some patients. And if this is recommended, how can patients feel confident that this will be as effective in terms of reducing their risk as a standard length of treatment would be?
I think that decision is a very individual decision between the patient and the doctor, and often has a lot to do with either where they are in their treatment, the intent of their treatment, and the risk reduction sort of afforded by their treatment, because you have to take all of those measures into account. So the unfortunate thing about cancer, as all of our patients know, is that cancer is not sheltering in place. And so we can't lose sight of the fact that, hopefully at the end of the day, when all of this is behind us, we don't want to have greater risk of cancer recurrence than we would otherwise have. So it's a very dynamic discussion, I think, between the patient and the physician. For a patient, for example, who has a metastatic cancer, who is in really, good remission, has been doing well on a therapy for a number of months or years, and who may be perhaps elderly and a bit more frail, if that discussion between the patient and the doctor is, maybe let's take a look at this therapy week to week, because we may have a lot more information, in a few weeks about where our community is going to be on this spectrum, then that doesn't really compromise outcome in any way, and maybe a good way for that patient and that physician to, again, ensure the best outcome for that patient. When you're talking about treatment, adjuvant treatment or neoadjuvant treatment, pre or post-operative therapy that we're giving with curative intent, we have to be very careful not to compromise outcome as a basis of dose reduction or schedule change. There are some opportunities that we, again, use always routinely in our practice. If there's a toxicity that the patient hasn't recovered from, or if there is a need for dose reduction for other reasons, there may be a very reasonable opportunity to think about those things and know from the data that we're not going to compromise outcome. But I think that to just simply blanketly say, well, I'm going to dose reduce 50%, or we're just going to stop here, is a conversation that has to be had between each individual patient and physician, and with an understanding of what those risks and benefits are. We do have different populations of patients, clearly. Those patients who have triple negative cancers, or those patients who have HER2 amplified cancers, their risk strategy is just different. And so we may have to have different conversations with them than we have with a patient who perhaps has the opportunity for endocrine therapy to complete the bulk of the risk reduction. So it is very individualized, and I think that there is definitely no one right answer. The American Society of Clinical Oncology, which is, for the medical oncologists, our sort of overriding body, has not made any specific recommendations for this, except that it has to be very individualized. It has to take it has to take under consideration the intent of therapy, and that there is no mandate, certainly, that there has to be a hold placed on therapy or a dose reduction placed on therapy simply on the basis of this pandemic.
Okay, gotcha. And so, what are you advising patients who are still doing chemotherapy in terms of limiting their risk from COVID-19 beyond what we're all social distancing, we're sheltering in place, all of those things, but do they need to take further steps like isolating themselves even at home, maybe from family members, and those kinds of things? What is the guidance that you're giving to them?
I think that also kind of depends on what their situation is at home. I mean, if they're at home with a family member who is also at home with them, and they're basically as sheltered as they can possibly be, then there probably isn't a need to isolate themselves in the home. You may have other patients, though, who have family members who are out in the workplace, and so perhaps depending upon whatever their risks are, there may be a decision to say, because we can't control your environment quite as well as we can control what's going on here in the home, maybe that's a better opportunity to social distance, especially if the other person is in a healthcare setting or, in another setting that might just be a higher risk setting to begin with. So I think it's again, a matter of looking at those individual risks. I think that as far as what we're trying to do globally is indeed just try to keep people at home as much as we can. So our telehealth platform, we're trying to use that for as many patients as we can, to just limit their need to come back and forth into clinic, especially with things that don't require an immediate physical exam or something of that nature, and then just limiting contacts. And I think from the standpoint of doing so, that's really one of the most important things, is how many people can we truly keep in their homes, and limit it here. What I would say, though, is that doesn't exclude patients coming to clinic when they have an acute need that we need to investigate. So if a patient feels a new mass on self-exam, that's not something that we can adequately assess with telehealth. And so that's something where we will say, okay, let's set up a time. We have all the screening procedures in place. We distance as much as we can and mask as much as we can until that time. But again, we can't allow concerns about COVID to interrupt the care that is necessary for all of our patients. And we don't want anybody to feel like they are essentially without care. I think the idea is that we are trying to make care as rational and as reasonable as we possibly can by offering these opportunities to do more of the distancing. But that does not take the place of those patients who simply need to be seen. And we will be there for those patients.
Great, wonderful. Well, another thing that's been coming up is in most breast cancer cases that are hormone positive, HER2 negative, surgery typically is generally the first thing that is done, and then the other forms of treatment follow. The recommendations have been changing because of COVID-19, and surgeries are being postponed. So if those clients that are having surgeries postponed, they're feeling nervous because they want to be sure that the cancer isn't growing or spreading, and they want to be sure that someone's able to kind of monitor them or help them understand or be sure that that's not happening. So how can, how are they monitored to ensure, or what can, how can we reassure them that the cancer isn't growing or spreading, and that other forms of treatment are working, and that we're still not affecting their future risk of recurrence?
So I think, and that is, one of the subjects that we really are taking as a group, surgery, medical oncology, radiation oncology, that we are having the most intensive discussions about to ensure that we are staying as strictly to the guidelines as we can in those situations, and also ensuring that each individual patient is discussed amongst that multidisciplinary group so that everybody feels comfortable with the decisions that the group is making. So the concerns about limitations on what are described as sort of non-emergent surgeries is several-fold. The first is obviously trying to conserve ventilators and PPE, which we all know now as personal protective equipment. The second is, in that vein, there is not just difficulties from the COVID, but also difficulties in getting supply because of COVID around the globe. We have to consider the patient's potential risk in that environment, the caregiver's potential risk in that environment, and how all these things can be put together. So again, in a risk model, the patients who have estrogen receptor positive, HER2 negative, early stage breast cancer represent a group of patients where we have an opportunity to potentially offer them a different treatment first, such as endocrine therapy, that may be a very effective way to allow us to ensure that their cancer is indeed not progressing, and yet keep them in some respects out of the operating room and out of the potential risk that may be inherent with the operating room in this time. There are other patients, obviously, that may not apply, and that's not even just in breast cancer, but in colon cancer and lung cancer and in other malignancies where surgery is generally considered the first step in treatment and maybe the only step in treatment. That is still not a one-size-fits-all. We have to take into account that patient's intent of care, what the future holds for them, what the potential risks and benefits are, and also to look again to the guidelines to say what do these national governing bodies think is a reasonable expectation of who can be treated in this way and who can't. For those patients, the medical oncologist is overseeing the endocrine therapy and the side effects and that kind of thing. And the breast surgeon is also very involved in seeing that patient frequently, doing clinical exams, doing ultrasound-based exams, once again to ensure that we're not seeing any adverse change. And so anticipating that, we certainly hope, that this is not something that is as lengthy as months and months, but I think what it will allow us to do is, again, understand who is having a good response, whose disease is well controlled, and who then, again, we can keep out of the operating room altogether for a while, versus if patients do seem to be having less robust of a response or concern about progression, well, those patients are going to go immediately into surgery. So there is still a potential to assess each patient and adapt to that individual patient. So it's not a situation where we're just going to place everybody on therapy and then just wait until whatever the go time is to take everybody then to surgery. I will say that there is also going to be in a very important, for patients who don't respond as well, then we are going to take them to surgery. But we also have to then sort of make sure that we're keeping close tabs on everybody, because at some point we're going to need to get everybody into that surgical realm, and we need to make sure they're all ready to go at that time.
Okay, sounds great. Yeah. So, and then for those who are in survivorship mode and maybe doing their, quarterly or twice a year, or even once a year appointments, how important is it to keep those follow-up appointments? Should they be scheduled further out? Should we be, you mentioned that a lot of these are being done by telemedicine. What's the viewpoint on that right now?
Well, I think for people who are doing well, we're usually offering them the option of the telehealth versus rescheduling. I think one of the reasons why the telehealth visits may be important, especially for patients who are maybe not so far out into their survivorship, is is basically the troubleshooting of the therapies. And, there are still things that we can talk about and manage, on the telehealth visits. I think the other thing, again, is this idea of keeping track and organization. So we also, in addition to taking care of patients now, have to think about the future when we have, patients who are all coming due for a mammogram at the same time and all, having these other things happen. So the telehealth visits are also a way for us to continually check and keep lists of, who's doing what when are we going to expect this? There's often a notation about, this, how when the mammogram was due. So we have to make sure that this mammogram is done, at that time, a little, sooner. So it's a way for us to not just, take care of acute issues right now, but also to make sure that the follow-up again in the future is as organized and as close to the schedule that we were hoping for as it could possibly be. That being said, somebody who's, on a 1-year follow-up, certainly if they were feeling comfortable saying, let me just reschedule till it's a more normal clinic environment, that's certainly very reasonable as well. The other thing is we are also trying to look at, who's had a recent exam. So often patients are seen by more than one provider. So if you haven't been seen in a year and haven't had an exam, then maybe that's something we're going to want to make sure that you're getting in very soon to have that exam done. Whereas if you've just had an exam by your surgeon or by your GYN, that might be a more appropriate patient where we can feel comfortable, okay, let's put you out to sort of a more traditional 6-month follow-up. So I think that the keeping of that appointment, or at least the communication about that appointment, is really about now, but also about the future.
Great, makes sense. Well, this has been so helpful. Thank you so much for joining me today. I really appreciate your time and your help, and thanks for all that you do for cancer patients in Central Texas. We are so grateful.
Well, we are here. We are not going away, and we're going to make sure that our patients are taken care of through all of this. And so we are truly in this together. We are partners, and more than that, I think we are truly connected. So we're happy to be here, and this is our mission. So this is what we do.
Terrific. Thank you so much. Thanks again.